Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. My name is Joe Saramelli, and I oversee Grand Rounds for our department. Back in October, we changed our Grand Rounds presentation format to a webinar, and we've had presentations covering generally four different domains, with suggestions coming from different advisory panels, faculty and trainees. And I wanted to mention again, we had fixed an issue with our post-presentation evaluation form. So afterwards, please take a minute to fill out the evaluation. It's helpful for planning the series and for communicating with the presenter later on afterwards. So today, we're fortunate to be joined by Dr. Jacqueline Hobbs, a leader and expert in quality improvement processes in graduate medical education and in clinical care. And some background about Dr. Hobbs. Dr. Hobbs is an associate professor of psychiatry at the University of Florida College of Medicine and is the director of psychiatry residency training program there and is the vice chair for education in the Department of Psychiatry. Dr. Hobbs completed an MD PhD training program at the Indiana University School of Medicine, followed by psychiatry residency completed at the University of Florida College of Medicine, and has been on the faculty there for approximately 15 years. Dr. Hobbs has directed the psychiatry residency training program for over 12 years and has served as vice chair for education for 7 years. And as vice chair for education, Dr. Hobbs leads and oversees a wide range of departmental education endeavors, ranging from undergraduate and medical education to graduate and postgraduate training. Additionally, Dr. Hobbs is the physician director of quality for the Department of Psychiatry and is involved in patient safety and quality improvement training for residents. Additionally, Dr. Hobbs is the associate designated institutional officer, official and chair of the program review committee and oversees the review of 84 residency and fellowship programs spanning over 800 trainees. And this work ensures accreditation of all of these programs. A couple of other points about Dr. Hobbs. Dr. Hobbs is the past president in 2018 of the Florida Psychiatric Association and was awarded the 2016 Practitioner of the Year Award by the Florida Psychiatric Society. Dr. Hobbs has also received awards of exemplary teacher by the University of Florida College of Medicine and is a distinguished fellow of the American Psychiatric Association. I'll stop for now and I'll turn it over to Dr. Hobbs, and I encourage you to write questions into the comment box and I'll keep track of those and we'll go through those at the end.
Thank you very much, Joe. It's really, that was really a very kind introduction. I'm very honored to be here sharing with you today. I will go ahead and share my slides. And I think that we're on the in the right place here. Someone can let me, yes, okay, good. All right, good. I'm just pleased. I've been involved with psychiatry education and quality improvement, as you just heard, for quite some time now, and I wanted to tell you a little bit about that educational journey. And I'm going to be talking a lot about shifting the curve today. So hopefully you'll come to understand what that means as we talk today. I have no disclosures of financial matters to disclose today. And our learning objectives are to determine how psychiatry residency and fellowship training programs can shift that curve. And we'll be looking at shifting from sort of thinking in terms of GME milestone development, not that we would ever leave that, that's very important, to getting to more where the clinical learning environment needs are. I will be citing ACGME requirements, helping you to be reminded of that. for faculty development and quality improvement and patient safety. I'll discuss practical ways of incorporating quality improvement and patient safety into faculty and resident daily clinical practice and education. And I will review the ECHO model of telementoring and engaging communities ourselves, actually, in psychiatry training in quality improvement and patient safety. So if you do have any questions, again, just put those in the chat, and we will handle those towards the end. So I'll tell you a little bit about our journey here at the University of Florida in terms of quality improvement and patient safety. So I'll start out with a little bit of my advice that I give to residents, fellows, and faculty about quality improvement and patient safety. You don't have to know it all from the beginning. You probably never know it all, but you definitely don't have to know it when you start. You can learn it just by getting in there and just doing it. I was back in 2007, I was sort of tapped by my chair at the time to become the physician director of quality for the department. I thought, well, that sounds great, but I had no idea what I was getting into. But I think you just have to have to be open to these types of experiences. So how did I learn about quality improvement and patient safety and then teaching it? Well, as I said, I've had a lot of on-the-job experience, 14 years of being physician director of quality. I've participated in various training mechanisms, like the AAMC Teaching for Quality. I've also did a 120-hour course, online course and graduate professional in healthcare risk management from the University of Florida. And I am certified by the American Board of Medical Quality. Basically read 3 major textbooks in the area and flew to Texas to take the board exam. And I highly recommend that to anyone who is interested in this field. It was a great experience. In working with my chair over the last several years, we've made this a theme of something that I'm doing along with education as part of my promotion packet. So I think that's something to always be thinking of, especially for those as junior faculty, or if you're a trainee who's thinking of becoming a faculty member. And again, just kind of getting in there, having a positive attitude, and having enthusiasm for this area is very important. So I'll tell you a little bit of background about our Academic Health Science Center. If you're not familiar with the University of Florida or UF Health, we're a tertiary academic health system. We're a level 1 trauma center. Our main hospital has about a little over 1,000 beds. Seems to be growing all the time, and many of those require psychiatric consultation. We have over 80 beds devoted to inpatient psychiatric care. And something that adds a little bit of difficulty for us sometimes is that our psych beds are about 10 miles away from the main med-surg hospital. And I'll touch on that a little bit as we go. We have multiple outpatient clinics throughout the city and actually throughout the state. And we are experiencing regional expansions, which probably is not unfamiliar to you as well. I will tell you a little bit of some milestones along our 14 years on the patient safety quality improvement journey. I mentioned starting out as a physician director of quality. Not long after that, I became the residency training director. In 2011, we had our first annual quality and safety day where our residents presented their projects. And in 2020, if you jump all the way to the bottom, you see that we had our 10th annual last year. So basically, in that intervening time, we've had a lot of things going on. We've done a lot of root cause analyses, which has allowed us to look at our events, patient safety events, and to engage in process improvement. We've had a lot of resident QI projects, and faculty have been involved with that. So lots of their time and effort has been put into this, and lots of topics, major quality and safety topics that have been covered. Since 2015, I've written over 230 what I call Tuesday's tip for quality and safety, and I'm going to show you a couple of those in just a moment. I'm also going to talk to you about our UF Health Behavioral Health Work Group, which I think is a big part of our culture of safety here. I was fortunate enough to get an ABPN Faculty Innovation and Education Award in 2017, and was able to develop 7 quality improvement and patient safety training videos. I'm going to show you a little clip from one of those. And then I'm going to talk to you some about some of our projects and some of the things that we've been focused on in improving, and again, kind of engaging in this culture change. So for the Tuesdays tips, most Tuesdays I will send out an email to department and our psych hospital. We also put these on an intranet site that's that others can join as well, and be able to see these tips. So they're quick. They come on the same orange. You know, we're big into orange here, orange and blue as Gators at University of Florida. And so everybody kind of gets used to seeing these come every week, and they're just quick tips. I want them to always be short, something that's easily digestible. Sometimes it's just a link to a video or a helpful handout. If we've had a recent event and we've learned something, we've got a process improvement, we'll talk about those. Sometimes we try to make them funny, you know, anything to be engaging as well. I mentioned the videos that we've produced, and I will show you a short clip of these. The videos in full length are less than 10 minutes, and that's important, I think, for busy clinicians that we want to train. This video is used to train all of our psych hospital employees and residents and fellows and faculty, and we do this on an ongoing basis. And I will start the video.
Let's look at some improper door procedure first. Note how he does not check his surroundings or look through the window. He also opens the door widely and does not ensure closure, which could allow a patient to easily escape. Let's look at another example, this time of how proper door procedure may be forgotten and lead to patient escape. Can you spot the error? Now let's look at how to properly enter or leave a locked psychiatric unit. Note how she looks through the window. She checks her surroundings and quickly opens the door with just enough space for her and ensures proper closure with her hand. To prevent elopement, use proper door procedure. And remember, use it for every door, every time to save lives.
All right. So again, we try to use these videos. We use them for our interns when they first come in. So I'll have them watch the video, and then we'll also just go and practice in person to solidify that further. I'll switch gears and talk a little bit about our behavioral health work group. This began in 2017. It was really started in the emergency department from personnel there, and also other quality improvement staff who were interested in behavioral health issues. And they were really focused on making sure that patients, this vulnerable population, got dignified care, and things like trying to transport patients, again, from our main hospital to the psychiatric hospital 10 miles away, making sure that that was safe, secure, and dignified. But this group has grown over the years as very multidisciplinary. You know, we as psychiatrists got very involved in it, but it's just wonderful, wonderful group of people. And several of hospital leadership attends regularly when they can. Our VP for nursing, our COO, and our CQO are frequently there. We have many ongoing process improvement projects, or others have, and then they bring them to us for advice. You know, talking about elopement prevention, you know, how to track our patients on involuntary status throughout our system, handoff communications. You know, we spent quite a bit of time on, you know, working on procedures with COVID-19, telepsychiatry, very much a part of that. And we've recently had quite a reorganization of our hospital psychiatric services. So it's been a great place to communicate all of that and to educate as well. We see it as sort of a hub and spoke sort of concept, where our behavioral health work group is the hub, and then there are lots of other task forces from nursing, for instance, but other committees and units actually bring their projects, feed into the behavioral health work group, get advice, and go back to the work. And it's kind of a you know, constant back and forth to try to make things better. We also added a resident to the work group. Amanda has been working with us for a couple years now, and she's been really helpful, kind of gives us that boots on the ground perspective of things. And she's had a really nice project or two, or many. She's very involved in QI and patient safety. And I think that it's been a great relationship, where she's gotten to work with so many different people from different areas. And we use the PDSA cycle, Plan, Do, Study, Act, to really work through a lot of these projects. But I would say, you know, probably the most important thing that we do is that we have this very active hospital-wide, institution-wide, multidisciplinary forum for discussion. And then we problem solve, and we develop strategies for our psychiatric services. And I think ultimately we end up reducing stigma for our patients and our profession, because we do work with so many people, and they get to see us, and they really want our input on so many things. Our driving philosophy really is that the treatment of this most vulnerable patient population, you know, this can be, you know, how we treat them is a vital sign for the overall health and culture of an institution. And it really does improve the quality of care, and it invigorates those of us who are involved. I mentioned, you know, with the behavioral health work group within the department, we have lots of ongoing projects. You know, with COVID, a lot of things kind of got started and then kind of, you know, kind of stopped. And so we had to, you know, kind of go back and get started again. But we've really been working on things like our suicide risk screening and assessment throughout the hospital, both the main hospital and the psychiatric hospital, and been able to see good compliance with doing that. We implemented trauma-informed care back in 2019, where we trained all of our staff, all of our physicians, and including our trainees. And we, even during COVID, we were able to see that there was a reduction in aggression and physical assaults. Also, in the midst of all these things, we celebrated World Patient Safety Day, and I think that's another important thing, is just having these events, whether it's your quality improvement day where you're presenting projects, or just joining in something that's bigger than yourselves. You know, with World Patient Safety Day, it's September 17th, and one of the things they try to get you to do is to light up, you know, a monument or more on campus. So we lit up several of them in orange around the campus, and our residents wore, Amanda made over 200 of these orange ribbons, and so the residents and faculty wore these, and they took pictures, and they just had fun, and I think that's another thing, is sort of make this fun. So I'm going to be talking to you a lot now about faculty roles, what faculty can do to help in this process, you know, to develop yourself and to help residents in training. So I think you have to think about, you know, where your role will be in all of this. I say, if nothing else, you know, the best thing about it is to see those smiling faces of the residents when they have the culmination of their projects that they've been working on. They get to present them and show all their hard work. And so, yeah, who could pass up those smiles? But you have to ask yourself, are you going to be a faculty expert? Are you going to pour yourself into really spending a lot of time on this topic? Are you going to be a faculty mentor or coach for projects? Or are you going to be more like the general faculty member who, you know, is supportive and enthusiastic? You might not be doing all of those projects yourself. So where do we go from here? So I'll remind you about ACGME requirements for faculty. Faculty must demonstrate commitment to the delivery of safe, quality, cost-effective, and patient-centered care. And they must pursue faculty development to enhance their skills in this, at least annually, in quality improvement and patient safety. And also, you know, their practice-based learning and improvement efforts, which is related. So I mentioned that shifting of the curve, and oops, I think my slide didn't change. There we go. I mentioned this shifting of the curve, and we're looking to shift from the GME milestone way of thinking, which again, we're not going to get rid of that. It is a guide, it is a baseline, but we also want to get to where the clinical learning environment needs are. So with milestones, we often tend to think of, okay, so we're going from 1 to 2 to 3 to 4. We've got 4 years as psychiatry trainees, so we got a while to get there, right? But what the clinical learning environment needs, what the hospital needs, for instance, is to get there faster. So going from a basic level of participation, maybe kind of being on a QI team, kind of watching and seeing how it all works, to moving to advanced participation where you're doing a little bit more of the work, and then to basic leadership where you can actually lead a project or a portion of that project. So getting there faster and being able to sustain and grow in that over time, to where you become more of a leader as you get ready to go out into practice or to join the faculty. So part of getting there faster is, again, getting through these to level 3 milestones as quickly as possible, and then to 4 by the time that one graduates. So really being able to participate in analysis of patient safety events, participating in disclosure, and participating in local quality improvement initiatives. So the goal really is to merge GME and clinical learning environment needs and get to that high reliability organization that we all want to be. So again, how do we do this? And just kind of putting this into written form so you can see this. We want patient safety and quality improvement to become a part of daily clinical work from day one of training. And we want to keep in mind that this all should be driven by benefits to the patients. Our core purpose is really to take care of patients first. We want to be informed by the milestones, and again, getting there quickly. And we want to observe our residents and fellows applying that experiential learning in the clinical learning environment. And we want to reinforce it with didactics, but we all know that that's not going to get us to the point where we can actually do things and perform in practice. And along the way, we want to develop meaningful interpersonal patient safety and QI teamwork. So how do we get this into clinical work from day one for a new intern, for instance? Well, one of the things, I'm just giving you an example. It doesn't have to be this for you, but one thing that we were having trouble with, for instance, was that I would get a call from the chair saying, I heard about this event that happened, could have been hours, days, weeks, sometimes months ago, and we weren't kind of communicating up the chain so that leadership was aware of things. And so we just started asking ourselves, well, where does this all start? Well, residents and fellows are often on the front line. Can they help us? Can they recognize these events? It's important that they do, and that they learn about communicating up, communicating to supervisors. That's a very important part of ACGME training. So we developed this list of events, serious events that happen on our units, and we put this in our handoff. So it's a very visual table where you can just easily see if there were any events, say overnight or on a particular shift, and then it gets communicated to others. And we also teach that if something happens, then you contact your supervisor, and then it's their job too to keep moving that up the chain. So we work with faculty then to do the same. These things can also be a way to start clinical rounds and say, okay, what did happen in the previous shift? And we can talk about specific events. We can encourage to submit incident reports or patient safety reports, as we call them. And also, if there was anything that maybe the resident experienced that was hard for them, then we can also help support them as well as other staff. We also instituted this past year something called Project 8. We noticed that we had some we have access problems, just like a lot of people do, a lot of clinics do. And we had some patients that were just kind of being passed every year on and on to the next resident, and not a lot of change going on. And so we started to ask ourselves, how could we do things differently? So now when we have a new patient in the clinic, they automatically get scheduled for 8 appointments, and they are spaced a certain amount, 1 appointment, then 2 weeks later, 4 weeks later, and then we start to spread them out from there. And those can be changed as time goes. But the whole idea is to think about, like, making sure that the patient gets seen, but then also that we always have in the back of our mind, like, what goal are we trying to get to for this patient? And are there other resources, better resources, for them to utilize in the system? So, what is going to be the dispo for this patient? And we have a smart phrase that we use in our notes. The residents, they actually really like this. And then when they come to staff, they can easily say, this is appointment number 4. And then they can, the attending and the resident know, okay, so we're about halfway through. So where are we with things? And it really helps keep us all on track. Again, I'm trying to give some practical sort of things too. Very simple things. Like just the other day, I noticed this consult note from our sleep clinic, and they document quality care measures for sleep, and they put those into their notes. It's very simple. And I said, hey, we should do this for psychiatry. So we're actually thinking of doing something very similar in our notes to basically document that, yes, we can't counseled on certain things, that we, here's the diagnosis, and we've we've educated the patient on that. And also we're prescribing an evidence-based therapy for that. I also say that, you can't do it's very hard to do it all, right? So when I was getting my PhD and trying to work on my dissertation, my husband always told me, you're not here to solve the world's problem with your dissertation. So, do one thing and do it well. So that's one thing I try to do, is that, instead of like trying to focus on an entire note and giving feedback on everything in that note for a resident, I will pick one thing or just one aspect of clinical care, and I will stick to that like for a long time, and I will talk about it in every encounter every teaching session with the resident. And they have a chuckle over Dr. Hobbs and what's the latest thing that she's making them think about. But just like, are they getting labs? Are they getting the proper labs? Are they getting them timely? It could be their thyroid function testing, and we talk about it. We talk about the importance of it. Right now I'm very focused on future orientation. I love for residents to get a sense of, are the patients thinking about being alive, whether it's a few days or weeks or months from now? Do they have plans? And so I really get them to think about that and to document that in their mental status exam. And I will give them feedback on that over and over again. So and now they come to me and they're like, here's what I'm going to put in there, Dr. Hobbs. So I think as a general faculty member, if you can just remember to do one thing and do it well, that can be a great help in patient safety and quality improvement. And if nothing else, again, just show your support. Like I always put our big aims for quality and safety for our institution. I put it in my signature line, and again, it's just to show support and hopefully make people take notice and think about it. So what's really in it for, why should a faculty member even bother, right? You're busy, you have lots of things to do. Well, I would say look at your compensation plan. Whether there are incentives built in for quality care, that's one thing. Promotion, it can be a promotional track or part of a promotional track to do quality and safety, especially as some of that morphs into scholarly activity. It can help with maintenance of certification. There are ABPN requirements for this, doing performance and practice, for instance. Scholarly activity, again, it gets you more involved in that. And again, remember those smiling faces, working with the residents and fellows. It can bring new horizons for you. Again, I had no idea that I would be working in this area when I started my career. So, you just have to be open to these things. And it really has brought me a lot of career satisfaction and I think well-being, to be part of something, again, something that's bigger than myself. So in terms of, where are we going from here with, our journey here at UF and also at the University of Washington. So I'll show you how we sort of came to know each other. So one of your faculty members, Ray Zhao, he is he's been my sort of partner in all of this as part of the Program Director, Patient Safety and Quality, PDPQ Educators Network. And this is something that's being done by ACGME, the Organization of Program Director Associations for all the different medical specialties, Project ECHO at the University of New Mexico. And so we actually have been, Ray and I have been involved, and some others, I'll show you in just a moment. We have been very much involved in this faculty development for program directors over the last several months, and will continue through June to be learning how to better develop training curricula and quality improvement and patient safety. There are key buckets that we're kind of working on, learning about, including stakeholder engagement and faculty development, curriculum development, and then learner and program assessment. You know, how are we doing in terms of how we teach quality improvement and patient safety? Again, all of these organizations have paired up and they use the ECHO model. And this is a telementoring methodology that sort of creates, usually you think of it as creating this distance learning, this community of practice, medical practice. But what we're doing with Project ECHO in this case is this is more about communities of teaching and teaching about quality improvement and patient safety. And again, it's distance learning. We do it through like a Zoom platform sort of thing, and we're able to basically have experts, you know, who are from all over the country, and then we also have learners from all over the country. And so we're moving the knowledge, and in this case, not patients, whereas if you were doing this in a medical model, we're doing it, we're not moving our teachers. We just have them all come together in a virtual platform. And ACGME started this out with 3 specialties: emergency medicine, neurosurgery, and internal medicine. And then this round, those have continued, and then they've added family medicine, OBGYN, psychiatry, and peds. So this is our first round. And so each round they're going to be adding and amplifying all of this. They're eventually going to have sponsoring institutions like our institutions who are going to sort of have their own part in this. They'll be involving the DIOs, the GME leadership, in amplifying this learning platform. And ADPERT, which is our program director, our psychiatry program director organization, we were chosen, as I said, as a specialty in this second round. And Ray and I are team co-leaders. So we each have a team at our institutions. And then there are others, we were recruited some other institutions to also join and have a psychiatry team. And it's usually made up of program director and another faculty member at least, sometimes more faculty members, and sometimes even some residents join in. Our UF psychiatry PDPQ team is myself, Mary Mermani, and Uma Suridavara. We've been engaged in this 6 months of weekly faculty development. They're 1-hour sessions. We have assignments in between, and we practice the ECHO model. Your UW teams, again, led by Ray, but also Anna Ratzliff, and you can see several others who have joined in as well as part of your UW teams. And ultimately, what the plan is that ADPERT would have their own ECHO model. And so we're going to be working with leadership of ADPERT to develop this and to continue this. So we'll continue sort of in the learning cycles with ACGME, getting various teams sort of trained up, but then also to go off and do our own ECHO. And I bring you back to the whole concept of shifting the curve here. So by training our faculty and our program leadership to better train our residents, we will hopefully shift this curve to the left and up, and hopefully be able to help our clinical learning environments to meet their goals while we're meeting our educational goals. And I'll leave some references with you and take any questions at this point. And thank you so much for your attention, your participation. And if you have any feedback, please just let me know. I really appreciate it.
Thank you, Dr. Hobbs. And I think, doing QI is something some of us have participated in, and we can all sort of incorporate, as you've described, at different stages to try to do the best we can in clinical care and in education, making it a routine part of practice. Thank you. I want to encourage participants to write in questions, comments. One comment came in from Dr. Ratzliff saying that there's already an active work group. I mean, those of you participating can read the comments, but there's an active work group for this as part of participation in the National Learning Collaborative. And anyone interested in working on the PSQI curriculum to reach out to Dr. Ratzliff directly.
Absolutely. Yeah, and Anna's been, and Ray both have been very active, and I know you guys have you have a lot of active things going on in this area, and it's humbling actually to be able to talk to you about everything that you're doing. But obviously, like, things change, right? Our institutions, there are shifts in how we do things, and we have to be ready for that, and that's what we need to train our residents and fellows to be ready for as well.
Thank you. And as others think over questions that they may want asked or answered, rather, I'll ask something, Dr. Hobbs, maybe more about you as an individual having expertise in research and in education. And I wonder how do I ask? Does QI at times, a trainee participating in a QI process or project, does that maybe at times initially seem more approachable than a research project, or are they similar? Yeah.
Absolutely, and I think even for faculty, to approach that, especially faculty who may not have had, research training themselves, it may just seem very, foreign, to get engaged and a little scary, right? Daunting. And so I think for residents, it's a great way to get your feet wet. That PDSA cycle, it's really just about thinking sort of in a systematic way, right? It's the same as scientific thinking, and so the big difference, I think, is that you usually go faster. You start really small, and you try to make a small change, and then you kind of keep expanding it as you go. So I think that's a little bit of the difference, and it's process improvement. It's not necessary. It's not kind of this big hypothesis driven, lab experiment sort of clinical trial sort of thing, right?
Now here's a question from Dr. Snowden. So in Dr. Snowden's experience, residents often want to take on very large, complex projects. Any advice on how to focus interest from something very large and requiring a lot of resources, probably large teams, down to something more focused that's achievable, which probably contributes to the motivation over time to have people achieve something early on?
Right. Right. Yeah. I mean, I think that, look for something in the clinical, in your clinical work, your daily clinical work that, seems like there's, that process could be tweaked and make it better. Maybe it's just something as simple as, providing an educational handout, on something. And so you start kind of like, you start really small, and you make something up, you make this handout or something, and you give it to, a couple patients, and you see how it goes, and you get a little feedback from them. And then you start to just build on this. So yeah, that was another thing. Even when I was, doing like bench research, I always had to remind myself, like, what do I even have access to? Like, what, if I need data, like, what can I actually physically get my hands on? Do I have the resources for that? So I think you have to think like that. You also have to reach out to mentors who can help you and kind of help you refine like how you're going to think about this.
Thank you. I wonder if we might, I mean, Dr. Ratzliff did write in a question. I wonder if we might just kind of model this for a second. Let's say I'm a trainee or even a junior faculty member, and I approach you, Dr. Hobbs, and I say, what I want to do for my project is make it so that every patient admitted to our hospital service with mania has complete resolution of manic symptoms in 5 days. That's my goal. That's what I want. So that's my QI project.
Yeah.
How does that sound? Can you help me turn that into an immediate next step?
Yeah, so I think that is such a laudable goal to have, right? I mean, we would all love to be able to do that. I think that we kind of have to take that sort of to be able, one manic patient doesn't equal another manic patient, right? There's like so many different variables that are in there. So maybe we have to start with, is there a certain subpopulation that we really want to look at? Is there, just maybe one or two patients that, again, maybe we want to try something. We want to, we always want to make sure that, that they get their lithium level on this particular, when they're admitted. Maybe that's the first step. That's something very simple. Like, is that being done? And is it being repeated? The next step, is it being repeated on a certain day? We can break it down into very small parts and see, if that's being done on just a handful of patients. And then we move to, looking at it in a bigger scope.
Thank you. That sounds like something I can do with the resources I have access to.
Right. Okay.
And the role play. Okay, now, Dr. Ratzliff question. Appreciating your benefits to the faculty, benefits the faculty with doing this work. I think there were 3 or 4 different ways that you had identified faculty to do this. Are there particular strategies for engagement of faculty in your system that seem to work well, or maybe ones that didn't work well?
Yeah, so I obviously you can't just kind of like cram this down, and say, hey, you're going to do this kind of thing. I think that, several of our faculty have, they've wanted to be involved, but they just feel like they don't know enough, and it seems daunting. So sometimes what I'll do is just pair them up with another more experienced mentor for quality improvement projects. So they're kind of learning like a junior resident would learn, right? They kind of can watch the process. They can give, clinical, they're great clinicians, so they can give, the clinical feedback. They can say, hey, I know that we're doing this in our clinical work. And then they get to see how the whole process works. So I think that's another thing, is just helping to mentor junior faculty in doing this. That's one thing that I think has worked, and our faculty like it because, again, it's part of our compensation plan that, if they're involved in sort of leadership and training, in quality improvement, they can get some incentives from that.
Oh, that's interesting. I know you, now that you're saying that the second time, I realize you presented on that or
Right.
mentioned that. And is that school-wide or is that unique to the department?
It's the college.
No, it's the college, excuse me.
Yep.
College.
Mm-hmm.
Okay.
Yep.
So faculty may pair up on an existing project. I mean, it's, yeah, it's interesting.
Mm-hmm.
If we get back to the question that Dr. Snowden asked about, part of his question included data. Do you have data analysts that work with trainees? Is that necessary for QI projects? Can you comment on quality of data analysis, how you handle that?
Yeah. So we actually, in our psychiatric hospital, we have a full-time risk manager, and in that role, they usually, we've had a couple of different people, but they very much can tap into a lot of data, and they can pull data for residents. They will often, they're already presenting it for other things, like if it was, say, seclusion and restraint or something like that, they can pull that and they can help the residents to find it. They can help them to analyze it. They can help them to present it. So I think that's very helpful. Anybody you can have who has access, and that's what I try to get the resident teams to really pair up with someone from risk management or from quality who can get that for us.
I invite others to write questions. I wonder, just to keep this going, if I get back into, imagine I'm a trainee or junior faculty. Okay, I followed your advice, Dr. Hobbs, and I found out that only about half of people prescribed lithium treatment in our hospital system have a concentration checked somewhere between day 4 and day 5. I'm surprised by that. I thought I was doing this regularly. What should I do?
That's a very good question. So, I think that, one, you can sort of brainstorm yourself and with your mentor about it, but I think too, like involving others, like, especially if you have IT specialists who are helping with, we have Epic, so, whatever your EMR is, maybe a best practice advisory, a BPA, can fire, when someone is prescribed lithium. And so there's a way to remind that this needs to be done. So maybe that's something that can be implemented. That might be, a good way to make sure that happens. I mean, if you can't do something like that, maybe it's, you have to kind of, if you can't hardwire it into the system, which is always what we're striving for, right? In making it, easy for people to do the right thing, then we do education, we do something that helps to make sure. Maybe you look at it and say, maybe the residents are writing the orders, but they're not being carried out. Mm-hmm. So you have to kind of dig. So you like pair up with your nursing, unit manager and ask them, like, can you help me look at this and see, if there's some, stop here that we're not getting to. So I think it's, it's a lot of just thinking through what are the root causes of this, and ask ourselves over and over, why?
It is interesting. Yeah. And with so many different interactions, so many different possible explanations. I mean, it's a lot like thinking about a clinical problem and what might be an explanation. It's very interesting. Right. I could see that this could be motivating for a lot of people to participate in a process like this. Yeah. A new question came in regarding sample size. how does the principle of sample size improve the power of study? Does that apply to QI projects? How do you think about that?
Yeah, it's not the same as a scientific study, a research study, where you really want to look. You're really looking at process improvement. So again, you start with very small, very manageable handful, couple handful, and then you just keep increasing until you can really see that you're getting this process improved and that it's going to be, and then you watch it over time just to make sure that if you implemented some new change, did it stick, is it continue to go, or does it, if you stop watching, does it go away? So there's kind of this process of just constantly doing and monitoring, and doing a little bit bigger PDSA cycles as you go. But yeah, you don't have to have the same sort of power that you would for research.
Yeah. Is there, from Dr. Empman, is there a resource you could point us to for quality and safety initiatives in psychiatry? What has been tried at other institutions? Is this consolidated somewhere? Is there a registry of initiatives, for example? Maybe this resource could broaden our list of possible interventions for PDSI cycles locally.
Yeah, there was a publication, a book that was out by Geeta Jairam, which I think summarizes a lot of patient safety sorts of initiatives, and I can try to pull that and send that to you, Joe. I think that's one thing. I think that there's going to be more coming out, and I think that's what ACGME is really focused on with this as well, is to develop and have more resources for this, and I think it's incumbent upon us in psychiatry and ADPERT to really make these things available. Now, ADPERT does have some model curricula that are available on quality and safety, and Claudia Reardon also has a publication on this topic. So I would say check those out, and again, I can try to get you those.
Thank you.
Mm-hmm.
Well, it looks like those are all the questions in the chat and in the Q&A. If any participant has something more to ask, please interrupt me and write it in. I'll say, to the sample size point, I think when I first learned about QI as it applies to clinical processes, the person instructing our group gave the example outside of a clinical setting about getting a child to school on time in the morning. And the crucial intervention ended up being toasting the Pop-Tart earlier, which
Right.
after multiple PSA cycles. It was very interesting.
Exactly.
Yeah.
Exactly. Yeah.
Anyway, off topic.
I
Well,
like it.
Dr. Hobbs, thank you very much for joining our Grand Round series today, for presenting on this, for talking over QI as it applies to clinical settings, GME in a larger way, how to get faculty involved, how to see projects through for residents to the culmination of a project. And I appreciate it very much. Thank you.
Yeah. Thank you so much. Thanks,
All right.
everybody.
Take care.